Takotsubo Cardiomyopathy, or TCM, is a form of acute reversible heart failure. It often mimics myocardial infarction, but without angiographic evidence of obstructive coronary artery disease or acute plaque rupture. It's often in response to severe emotional or psychological stressors. It's usually seen in postmenopausal women. TCM in the setting of acute alcohol withdrawal has seldom been described. This is a case of a 47-year-old with a history of alcohol use disorder, ulcerative colitis, and hypertension. She was admitted for seizures, altered mental status, and hypertensive emergency. She usually drank about 5 to 6 shots of hard liquor a day and had not consumed alcohol in over 24 hours. On initial presentation, she was intubated and hypertensive and tachycardic. Several hours after admission, her troponin increased to 2.2. EKG showed T-wave inversion on the anterior lateral leads, which was concerning for ischemia. A TTE showed severe global hypokinesis with apical dyskinesis, with spraying of the basal segments. This is consistent with TCM. She had an EF of 13%. She was started on ionotropic support. Further EKG showed worsening T-wave inversion with a peak troponin of 3.5. She subsequently became hypotensive with vasopressor requirements. Right heart cath showed severe hypovolemia in the setting of cardiogenic shock. Goal-directed medical therapy was initiated. In the following days, she underwent left heart catheterization, which showed non-obstructive cardiomyopathy with no evidence of plaque rupture or obstructive coronary artery disease. The patient was further stabilized, transferred out of the ICU, and discharged several days later with the plan to undergo alcohol counseling as an outpatient. TCM is characterized by severe left ventricular dysfunction with regional wall abnormalities, new EKG changes indicative of ischemia, absence of angiographic evidence of acute plaque rupture, the absence of myocarditis or pheochromocytoma. One widely accepted theory in the pathogenesis of TCM is due to increased release of catecholamines in response to an acute stressor. Excessive adrenergic activation has been shown to cause myocardial damage in the setting of hypertensive crisis and pheochromocytoma, with proposed mechanisms including vasospasm of the distal coronary arteries and microvascular disturbances. This leads to regional wall abnormalities. It is well known that alcohol withdrawal results in unopposed adrenergic activation. However, the cytotoxic effect on cardiomyocytes in these situations has only been demonstrated in animal studies. TCM is rarely reported in the setting of acute alcohol withdrawal, possibly in part due to patients not undergoing extensive cardiac workup. It's important to recognize this complication in patients with ACS-like signs and symptoms.